the preemie brain that is affected by some particular pathologies. And finally, the bigger chapter is neonatal encephalopathy. So how is the neonatal brain? If a child is not a small adult, we can know very well, a newborn is not a small child. So the first important difference is that, as you probably know, the brain of a newborn is almost completely unmyelinated. So the conventional T2 weighted image and T1 weighted images are very different from the adult one. White matter is completely hyperintense on T2 weighted image and hyperintense into T1 weighted image. So they are completely different from the adult brain, in which white matter is typically hyperintense and on T2 weighted image and typically hyperintense on T1 weighted image. And that's due to the fact that there is no myelin, and myelin is rich in lipid, and the presence of myelin reduce water and increase lipids. So this changed dramatically the signal intensity of the white matter. That's important from a technical point of view, also for the sequence of acquisition that may change, that has to be changed. If you look at the relaxation time of the white and gray matter in an adult and in a newborn, you can see how these are different. And so if you are looking for the maximum contrast between the gray and white matter in an adult and in a newborn, you can see, for instance, on T1 weighted image, that the repetition time should change from the classical 700 to something around 1000, 1000, so something completely different. So you have to change your acquisition sequence from the adult one for T1 weighted image, but also for T2 weighted image. You can see here how the TE, the echo time of the classical T2 weighted image acquisition, change from an adult from a newborn. If you look for an optimal gray-white matter contrast, TE should be changed from something around 80, 19 milliseconds to more than 200 milliseconds. You can see here, this is the maximum area of contrast between gray and white matter in for T2 weighted image in a neonates in comparison to the adult one. And you can see here some example. So the optimized sequence for T1 weighted image should change the repetition time to something around 1000, and the optimized T2 weighted image should change the echo time to something more longer than 200. You can see here an example. In this case, a newborn with a diffuse malforcortical malformation is started with a TR of 3000 and TE of 80. The contrast could be quite good, but we can do better with a longer TR and longer TE, and also better with a TE of 180 or a TE longer than 200, in which the contrast is maximized. So you have to change your acquisition protocol, and you have to image to have different protocols for different age. Of course, this kind of sequence is true for newborn and for kids around 3, 4, 5 months of age, but then you can change once again the TR and the TE, and probably you have just at least 3 or 4 different protocols for different ages. For flare, we have something particular because flare change his contrast from neonates to toddler to 3 years age kids, and sometimes it's difficult to interpret flare, in particular in newborn. So my suggestion is use flare with care. Of course, you can use flare after gadolinium because in flare there is also a T1 weighted component. So it's very interesting in contrast when you use gadolinium. But in the other instance, use flare with a particular attention because you have some misinterpretation with flare. So T1 and T2 are the more important sequence in newborn. Of course, you have to optimize also spatial resolution because the head of a newborn is small, of course. So, of course, if you have a 3T, is a better solution, but also with 1.5 Tesla, you have to optimize your voxel size. So try to obtain the maximum of spatial resolution with your unit. So which is the standard sequence? T2 in a newborn, T2, T1, of course, diffusion weighted images are important in any case, DWI and ADC. And if you have it also, susceptibility weighted image could be very important. Sometimes, and we will see spectroscopy and spill labeling are important. So this is the normal appearance of the T2 weighted image and the T1 weighted image in a newborn. As you see, these images are okay. These images are with very few myelin. Myelin is just in the supratentorial compartment in the posterior limb of the internal capsule here. You can see probably better on T1 weighted image. You can see here the hyperintensity in this case is just due to the presence of myelin, but is the only part of myelination white matter that you can see in the supratentorial compartment. So, what about the preterm brain? In preterm brain, you have to increase further TR and TE because white matter is extremely rich in water. You can see T2 weighted image of 28 gestational week preemie, 33 gestational week preterm newborn, and a term newborn. You can see, of course, how the brain change is morphology. At 28 age of gestational week, the brain, the surface of the brain is extremely smooth. Of course, there is no myelin in the pleek. Also, on 33 gestational week, there is still no myelin in the posterior limb of the internal capsule, and you can see myelin only in the term newborn. In preemie, you can see on magnetic resonance a very important structure, that is the germinal matrix. The germinal matrix is a transient layer that is in the surface of the ventricle and is present in the fetal brain during a large period of gestational age between 8 and 36 gestational weeks. And you can see here, this is the region of the germinal matrix. And you can see how the germinal matrix is very dark, is incredibly hypo intense on T2 weighted image because is very rich in cells. From the germinal matrix arise all the cells of the brain, both neuron and glial cells. And you can see here how the germinal matrix change in volume during gestation. These are all fetal autopsy. And you can see the germinal matrix volume reach the peak, the maximum, around the 22, 23 gestational weeks. Then there is an involution of the germinal matrix. And in this period, you can see very frequently some cysts, typically by ultrasound. These are ultrasound section. Typically, these cysts that are called germinolithic cysts are absolutely benign, paraphysiological cysts with no pathological meaning. But germinal matrix is very fragile. So one of the most frequent brain disease in the preemie is just germinal matrix hemorrhage. What we know about germinal matrix hemorrhage? We know that the incidence is greater in very small preemie and in very low birth weight infant. The risk of germinal matrix hemorrhage increases, in fact, with decreasing gestational age. There are a lot of problems because in surviving infants born at 24 gestational age, the incidence of the most severe lesion related to germinal matrix hemorrhage is between 10 and 25%, so it's very high. Germinal matrix hemorrhage, on the other hand, is rarely observed beyond 32, so gestational age. So the period of maximum risk is just in very, very low birth weight infants. The pathogenesis of germinal matrix hemorrhage is multifactorial. As we said, gestational age is the most important single independent risk factor, but also the particular vessels that are present in germinal matrix is another important reason that lead to hemorrhage, because in this vessel there are no pericytes, and this means that these vessels are very fragile. So any fluctuation in cerebral blood flow, in venous pressure, can lead to hemorrhage within germinal matrix. The grading of germinal matrix, the grading that is diffusely used, is still the Papille grading. This grading was made up in 1978 with CT. And in this grading, we have a grade 1 in which the bleeding is limited to the germinal matrix, a grade 2 in which the bleeding is present not only in the germinal matrix, but also in the ventricular area. And if ventricular lumen is occupied but hemorrhage less than 50%, we have grade 2. And if a ventricular lumen is greater than, is occupied more than 50% by hemorrhage, we have grade 3, and we have grade 3 also in case of ventricular dilatation. In grade 4, we have not only a germinal matrix hemorrhage and the intraventricular hemorrhage, but also a parenchymal extension of this hemorrhage. And the most recent year, we change our view, and Volpi in 2008 make a first modification of this papille grading, and more recently, the European ultrasound brain group subdivided the germinal matrix hemorrhage in a more complex grading, considering not only the germinal matrix hemorrhage, but also the presence of the intraventricular hemorrhage, and in particular, the presence of periventricular hemorrhagic infarction, PHI. And with this new grading, we know that also with a grade 2 of a germinal matrix hemorrhage, according to papille, we can have a extensive intraventricular hemorrhage, or we can have periventricular hemorrhagic infarction, also in grade 2 or in grade 3. So the reality is a little more complicated than papille said in 1978. So which is the role of MRI in evaluating this kind of disease, and more generally speaking, the brain of the preemies? We have a lot of difficulties in study preemies, because to study a preemie before the 32 gestational week, we need more often a MR-compatible incubator. Possibly we must have also some dedicated neonatal brain coils. Of course, as I said previously, we must have some tailored MR sequences. So we usually do not perform this kind of study in a standard clinical setting, but more precisely as a research studies. And what we can learn from this study? But of course, as I said, the brain of the preemie are very difficult. You can see here in this case of extensive intraventricular hemorrhage, but look at the white matter and also at what we can identify as basal ganglia and thalami. They are diffusely hyperintense. So we can say that probably in this preemie there is a diffuse brain edema, but the problem is that it's very difficult to understand the presence of brain edema. That means water, and water is hyperintense on T2-weighted image. It's difficult to see that when the white matter is normally hyperintense. So it's difficult to differentiate something that should be a little more hyperintense than a normal brain. But in this case, we have no doubt that there is a diffuse edematous brain. You can see here, of course, magnetic resonance may depict very well the presence of hemorrhage, can depict very well the presence of this thrombus, this coagul here, and the increase in size of the supratentorial ventricle. Can depict very well in these two cases how the clot is present within the aqueduct, leading to a occlusion of the aqueduct and also to the Magendie foramen, so a dilatation of the foreventricle. But what is interesting on magnetic resonance study is the possibility to study with high contrast and high spatial resolution how the medullary veins are involved when there is a huge hemorrhage within the germinal matrix. The presence of a huge hemorrhage here causes a stenosis of the terminal vein, then reflects to the medullary vein that becomes engorged, and you can see here how the hemorrhage developed within the area of the medullary vein. So the secondary ventricular hemorrhagic infarction is actually a venous infarction secondary to engorgement of the terminal vein and of the medullary veins. You can see here very well how MRI depicted all the blood within the region of the medullary vein and this huge periventricular hemorrhage in case of primary germinal matrix hemorrhage. You can see here also in the coronal view, all these images are related to the dilated medullary vein that are full of clot, full of hemorrhages. And we learn with magnetic resonance that also in what we previously call a simple grade 1 germinal matrix hemorrhage according to Papille, something happened also in the periventricular white matter, once again due to the engorgement of the medullary vein here. So we learn that intracranial veins are very important in the pathogenesis of brain damage in the preemie brain. And even without major sinus thrombosis or with minor germinal matrix hemorrhage, we can find this dilatation, these are susceptibility with the image study. You can see here the enlargement of the medullary vein that leads to periventricular hemorrhage. And we are now able to see this also in fetal study. You can see here, once again, periventricular hemorrhage with venous engorgement. Look here, how is dilated the jugular vein, how is dilated the rectus sinus, the vein of Galen here, and the venous compartment is very fragile in the preemie. Look here, a dramatic intraventricular hemorrhage with a diffuse parenchymal hemorrhage along the course of medullary veins. And you can see here. And what is interesting, and in the follow-up, this dramatic end stage of this lesion can mimic the so-called periventricular leukomalacia, but it's not a periventricular leukomalacia. This damage is originally an hemorrhagic damage. So what we can conclude about the premise, germinal matrix hemorrhage is the principal source of hemorrhage in premise. Germinal matrix hemorrhage affect periventricular region, but you must remember, we have no time to speak about this, but also cerebellar hemisphere can be involved, in particular in premise around the 24-26 gestational week. Magnetic resonance cannot be used in the routine setting in a very small premise, but with this study we understand how venues are very important, and in particular deep medullary vein engorgement and thrombosis can be found even without major sinus thrombosis or with minor germinal matrix hemorrhage. So, coming to term newborn. What is neonatal encephalopathy? Neonatal encephalopathy is a generic term and is a clinically defined syndrome of disturbed neurological function in the earliest days of life in an infant born at or beyond 30 weeks of gestation, so term newborn. Manifested clinically by a subnormal level of consciousness of seizure and often accompanied by difficulty with initiation and maintaining respiration and depression of tone and reflexes. So there are different conditions within this umbrella. Neonatal encephalopathy can be due by all these different conditions. But we know that hypoxic ischemic encephalopathy is still the most common cause of neonatal encephalopathy, even is not neonatal encephalopathy. Okay, hypoxic ischemic encephalopathy is the leading cause of neonatal encephalopathy. And we know that has still an incidence. This is relatively high, representing the third most common cause of neonatal death after premature birth and severe infection. But we know that in the last 15 and almost 20 years, hypothermia has significantly improved neurocognitive outcome in these kids, changing also the role of diagnostic imaging. So what kind of damage we can encounter in HIE, and what is the temporal evolution? We have basically two patterns in HIE. What we can call the acute profound asphyxia that leads to a selective damage of some part of the brain, namely basal ganglia, thalamus, some part of the cortex, perirolande cortex, auditory cortex. And we have something that is probably secondary to partial prolonged asphyxia, usually together with hypotension or infection and or hypoglycemia, in which the damage is typically in the watershed territories. Look here, a T1 Were image in a typical selective damage of acute profound asphyxia on T1 Were image after 10 to 20 days after birth. You can see that lentiform nuclei, the posterior part of these nuclei, thalami, in particular the ventroposterolateral nucleus of the thalami here, the Heschel gyrus, that is primary auditory cortex, the Rolandi cortex here, some part of the optic radiation, and you cannot find the normal hyperintensity on the plaque. So all these hyperintensity are definitely pathologic after 10 to 20 days after the insult. Why this aspect? Why we find some hyperintensity? We don't know exactly. Probably these are macrophages. There are plenty of foamy cells that are rich of lipids. But it's not myelin, it's not hemorrhage, it's the direct damage on these cells. So lentiform nuclei, VPL thalami, some parts of the cortex, you can see also here and here, optic radiation. Look here, Rolandi cortex, extremely bright, is hyperintense, still after 20 days after the insult. Basal ganglia. Look also at the hippocampus, that can be as well involved. And look here, primary auditory cortex, the Heschel gyrus. How about T2? On T2 Were image, this pattern is more difficult to understand. You can see in the acute phase how all the brain is hyperintense in comparison to a normal neonatal brain. This is due to a diffuse edema. In the subacute phase, in the severe damage, you can see this hypointensity in the VPL nucleus and in the posterior part of the lentifor nuclei. And you can see how this pattern is different according to the severity of insult. You can see here a minimal lesion at the posterior part of a lentifor nuclei. Lesion is in lentifor nuclei and also in VPL. Lesion is diffusely at the level of the basal ganglia in this more severe case. In this second pattern, on the contrary, the so-called partial prolonged asphyxia model, you can see here in the acute phase on diffusion weighted images how the watershed territories are involved. And in the end stage, you can see the dramatic atrophy, the dramatic lesion, balastic lesion here at the level of the watershed territory bilaterally, and even in coronal section, these are clearly seen. But the more frequent and typically related to HIE is the model 1, so the acute profound asphyxia model. And in this model, we can find a different condition in the acute phase, in the secondary phase, and we can encounter also a tertiary phase. What happened in the acute phase? In the acute phase, what is damaged is what is metabolically more active. So the part of the brain that needs a greater energetic requirement. And which part are in the neonatal brain? Something different from an adult, because as we have seen, only some part of the brain are actually myelinated. Look here, this is a cerebral blood flow map with arterial spin labeling technique in a newborn, and you can see how blood flow is different from an adult map, because only some part of the brain show an increase in blood flow, and in particular the Rolande cortex, the thalami, basal ganglia. These are just the area that are more sensitive to an hypoxic ischemic insult. And you can see also with PET, basal ganglia are in a newborn the region with the greater energy requirement comparison to a 4 years kid in all the presence of glucose in the gray matter is homogeneous. What happened to perfusion in the very first time of ischemia? We have the hypoperfusion in day 1 and hyperperfusion after day 1 in day 2. And you can see here also in a less severe case, hypoperfusion here and hyperperfusion in the basal ganglia. What happened to the standard T1, T2 sequence and diffusion sequence? This is a very severe case in the first day. Diffuse edema. All is hyperintense on T2 weighted image and is hypointense on T1 weighted image. And on diffusion weighted image, you can see any restriction, a dramatic, a striking restriction of diffusion in all the gray matter. And if you compare these images with a standard normal newborn, you can see how these are different. No difference or almost no difference between gray and white matter on T2 and T1 weighted image, a dramatic restriction of diffusion. This is a not so dramatic case, a moderate to severe HIE. You can see here there is some edema, but is diffusion weighted image that are very important at 3 days, because you can see very well a diffuse restriction here at the level of the VPL nucleus of the thalamus. This is perfusion, and in perfusion, As I said, it's the third day after insult, you can see an increase of perfusion. Spectroscopy could be helpful. Sometimes you can see here a relatively large peak of lactate that is typically found in the first phase of the insult. A moderate insult, 4-day, you can see almost nothing on T2 and T1, but you can see here an area, a small area of diffusion restriction. What happened in the post-acute phase at 8 days in severe HIE, you have something that is called a pseudo-normalization of diffusion. In this case, there is still some area in which you can find a diffusion restriction, but usually we, at this time, we have a pseudo-normalization that becoming progressively a ADC increase when in the chronic phase, you have this porotic malaysic area, and of course, this corresponds to an increase in ADC. So once again, what about spectroscopy? We have a dramatic increase in the very acute phase. We can have a pseudo-normalization in the first day, and then another increase in lactate. So it's important to consider this modification, these changes when you study in the acute phase a newborn. First day, increase of lactate, very well evident. 2 weeks, no more lactate after cooling. And in this case, we have a good result after cooling. 1 year follow-up, this newborn is clinically normal. At 4 days, you have probably a pseudo-normalization because, on the contrary, at 2 weeks, we have some evidence of a lesion here. So, but at 4 days, no significant lactate peak. So to summarize what happened in the first week, you can see how change the pattern on MRI on T1, T2, DWI, spectroscopy, perfusion. So it's very important to consider when we study kids. In particular, remember that if you study in the acute phase, the maximum of DWI restriction and diffusion restriction is around 2 to 4 days. But then we have a pseudo-normalization, so we can think that there is nothing, the normal, but on the contrary, there is some lesion. So hypothermia has changed a lot because we know that we have an improved neuroconditioning outcome until now, I think 10 years, 12 years of age. There is a reduction of the excitotoxicity, mainly due to the lower degree, 33 degree. And we know from this paper that the predicted value of MRI for subsequent neurological impairment is not affected by therapeutic hypothermia. But we know also that some injuries are missed by MRI. For instance, as said this paper, a small injury in the cerebellum can be missed. And magnetic resonance has recently pointed out another particular feature that is present also in case of hypothermia. You can see here 50% of cases with abnormal mammillary bodies, and these cases did not show any other abnormality after hypothermia. So you can see here There is an hyperintensity on T2-weighted image and a diffusion restriction in the acute phase. Of course, that's important because can affect the prognosis, and some cognitive and memory deficit in infants with HIE at school age probably is due to this lesion. So hypothermia, the predictive value of MRI is not affected by hypothermia. And MRI can be used in any case to evaluate the effect of cooling. Even with MRI, we can miss some lesion, for instance, cerebellum lesion. Look at the mammillary bodies, because mammillary bodies can be frequently affected. Chronic phase. In chronic phase, we have sort of hypertrophy of thalami with this residual lesion here. There's a dramatic lesion. Is not difficult to understand that there is something, so that there is a HIE. Sometimes in a chronic phase, if the clinical data are not very clear, you can see this very small lesion here. And you know, there are a lot of pathology that affected lenticular nucleus, so this lesion can be very non-specific. But if you see together this and this, so lesion in this region here, I think it's very suggestive for end stage of HIE. Neonatal encephalopathy means a lot of different things. I would just spend 2 words about metabolic disorder, because sometimes they can be entering differential diagnosis with HIE. Look at these 2 cases. They seem very similar. Case 1, MRI 12 days. Very similar to this case that is actually HIE at 10 days. Same location, Rolandi cortex, basal ganglia, etc. But look at this case at 26 days. Okay, what we can say is the end stage of HIE, no, is a classic citrullinemia type 2, is a metabolic disease that causes hyperammonemia, and hyperammonemia leads to increase of glutamate. So the pathway is very similar to what happened in HIE. But of course, the clinical is very different, because these kids, these newborn, appear normal at birth. And as ammonia builds, of course, they experience a progressive lethargy, poor feeding, vomiting, seizure, etc. So the differential is clinical in this case, is not related to images. Just to conclude, another very important item in neonatal encephalopathy is neonatal stroke, because neonatal stroke is not infrequent. First of all, we have to separate neonatal stroke, that is a stroke that happened between birth and 28 days, so in the strictly neonatal period, and perinatal stroke, but encompass not only the neonatal stroke, but also stroke happening in the fetus. So we talk only about neonatal stroke. They can be venous or arterial in origin. A lot of published cases for arterial ischemic stroke, but that not means that arterial ischemic stroke is more frequent than venous stroke, which are risk factor a lot. We have a lot of risk factors for arterial ischemic stroke, and the pathophysiology is for sure multifactorial. But what is interesting is that the location is, as you can see here, for something like 90% in middle cerebral artery, and also the 62% in left territory. So that could mean that these strokes are, in fact, embolic in origin from heart, like in the adults, in fibrillant old men. But we don't know exactly. What we know very well is that the clinical presentation, the typical clinical presentation of the neonatal arterial ischemic stroke are seizures. 90% of cases, seizures. We have this sign. This is the stroke, the area of stroke, and we have the sign of missing cortex. Where is the cortex? Of course, there is an edema, cortical edema, so bright, hyperintense, and this confound the gray matter with the subcortical white matter. If you look at diffusion weighted image, of course, you have a dramatic restriction, diffusion, that is maximum in the period from 2 to 4 days after the stroke. You can see here a magnified missing cortex sign. You cannot find the cortex because here there is an edematous cortex in the acute phase of the stroke. And to the end stage, you can see this porotic molastic area, no more cortex, a hole, I can say, and you can see here the comparison of the acute and chronic stage. And if you look at the ADC in the acute phase, this can predict the final stage. You can see the involvement of this part of the posterior part of the insular cortex here. You can see here the damage. You can see at this level, and you can see here precisely this part of the cortex is damaged. In the very hyperacute phase, you can see very well in ADC the selective involvement of the cortex. We can have an increase in cerebral blood flow and a vasodilation in this case. Sorry. But venous stroke is as well important. You can see here a huge thrombus in the superior sagittal sinus. But what is interesting in this case, that you have no lesion. So in this case, in this newborn, we do not have the typical venous infarction that can happen in an adult. So there is, of course, some possibly other territories to drainage with blood. What happened in this other case, 10 days, a very huge diffuse venous thrombosis, superior sagittal sinus, strike sinus, vein of Galen, also the transverse sinus. You can see here the venous image. So the only route for the outflow of the blood is just in the anterior part of the brain. But we don't find any huge lesion, how we can expect in an adult. But once again, this dramatic venous hypertension causes a venous stasi within and venous engorgement within the deep medullary vein, as you can see here. So the damage is profound. It's just in the deep medullary vein. You can see here the diffusion restriction at this level. And you can see in the end stage of this case, there is a progressive reperfusion of the superior sagittal sinus, but you can see very well once again the deep medullary vein, and you can see at 2 months this aspect of thinning of the white matter that resembles in part the so-called periventricular leukomalacia, even is more evident in the frontal part of the brain. So deep medullary vein engorgement is very important, but we have also the possibility to superficial medullary vein involvement. You can see the deep medullary vein involvement. We have learned that is very important because this can be different, and the end stage is a periventricular leukomalacia mimicker, but we have also a centrifugal small veins can be affected, you can see here. And in this case, they do not cause a profound hemorrhage in the white matter, but a hemorrhage in this area that is the subpial hemorrhage. The subpial hemorrhage is another typical feature of the neonatal brain. You cannot encounter this hemorrhage in our kids, in toddler or in greater kids, only in newborn, because the real laxity of the pial membrane with respect to the superficial cortex. So if you have an engorgement of this small vein and a subsequent hemorrhage, the blood goes into this virtual area and cause a subpial hemorrhage. And you can see here one case. This is just a blood within the subpial space. And what is important, that this blood also is present together with the cortical lesion. So where there is blood, very frequently the superficial cortex, the near cortex, is affected, so is ischemic, and we can have also a hemorrhage in the subcortical region. You can see here, once again, in the acute phase, the cortical is affected, and you can see very clear on diffusion wave image, because this is the restricted diffusion of the cortical lesion that appear together with the hemorrhage. If you look at the deep medullary vein, of course, they are engorged, but they are not responsible in this case of a primary subpial hemorrhage. And this is the end stage of this case. This is another case. Look here, 6 days. Look how the cortex is involved and how there is a profound hemorrhage that is due to the fact that the deep medullary vein have secondary involvement. This sign is called by someone the yin-yang sign. You can see the yin and yang facing, and you can see the susceptibility wave image that in these images you can appreciate very well the presence of blood. Once again, the end stage in which there is a damage of the cortex that is very evident here, and also in the subcortical white matter. Once again, the end stage. So, to recap, you can see once again the blood, secondary the cortical damage, and finally the blood also within the subcortical area. So, to conclude this chapter on stroke, neonatal stroke is a relatively frequent cause of neonatal encephalopathy. Ischemic stroke usually happen in the first 3 days after birth and affect mainly middle cerebral arterial territory. Venous hemorrhagic stroke is very important, and until now it is not completely recognized in its importance. It predominantly affects not the dural sinus as in the adult, but the small deep medullary veins or the small pial intracortical veins, causing or profound lesion or the subpial hemorrhage with cortical lesion. So I think that we have no more time, and I hope that I can offer to you a global view of what magnetic resonance and neuroradiologists can say in the pathology of a newborn brain. Of course, we can say a lot of more things, but I think that the more important things are neonatal encephalopathy and the possibility to MRI to be a very important diagnostic tool in make the differential diagnosis. So I will thank you for your attention.